Yeah, okay, move. Okay, so yeah, this talk is about musculoskeletal soft tissue tumors or soft tissue sarcomas. We did talk about bone tumors in the past, but today is more about soft tissue tumors or sarcomas. So the theme for this talk is to start covering all the imaging modalities we use for soft tissue tumors, starting from radiographs to ultrasound, CT, and MRI. We also talk about MRI techniques related to MRI coils, positioning, um, all the technical factors related to optimization of MRI imaging of soft tissue sarcoma. And also we'll talk about staging of soft tissue sarcomas, and then we'll move on to all the different types and examples of soft tissue tumors. We will have also quizzes as we go along. I think we have about 15 cases to cover. So the first imaging modality, as always in radiology, is X-rays. And with the utility of radiographs, you could actually detect some soft tissue masses on radiographs. You may be also able to detect soft tissue mineralization and calcification of soft tissue tumors, for example, synovial sarcoma. You may be able to detect phleboliths in soft tissue hemangiomas and also any bony destruction secondary to soft tissue sarcoma. Ultrasound can also be, and it's, in fact, is the first imaging modality when it comes to imaging soft tissue tumors. And the role for ultrasound scan, cystic and solid masses. So sometimes we get patient referred for suspected soft tissue tumor, but then when you do the ultrasound scan, you just discover it's a small synovial cyst or a small ganglion cyst. But that's where the role of ultrasound lies. It's if we detected solid soft tissue tumors on ultrasound scan, then we will recommend further imaging with MRI scan. Ultrasound would also be helpful to detect any internal vascular examples of tissue, AVM or hemangioma. They will be highly vast. So sometimes you can tell from nature of the soft tissue tumor is. And there are some typical tumors you may be able to detect with ultrasound scan and dismiss, for example, a lipoma. We do see quite a few patients who present with soft tissue masses, and if we detect can, we don't necessarily recommend further imaging with MRI scan unless there are suspicious features related to the lipoma, or if there is history of pain or history of recent increase or rapid increase in the size of the lipoma. CT has limited role in soft tissue sarcomas. We really need it if we are suspicious of any internal mineralization or calcification, such as in this case. That's where the weakness of MRI scan, because MRI scan is not really good at detecting soft tissue calcification or mineralization. And sometimes actually CT may be helpful for lesions that may be detected and characterized with CT, such as lipoma. And we see that all the time. Sometimes when we do CT scan of the abdomen or CT scan of the chest, we see soft tissue lipomas, and we don't recommend further imaging with MRI unless there are suspicious features. CT can also be utilized if there are contraindications for MRI, but that's really limited and very narrow area for characterization of soft tissue tumors. MRI is the major imaging test for soft tissue sarcomas or all soft tissue tumors, whether benign or malignant. MRI is very helpful for lesion detection, lesion staging for malignant soft tissue tumors and sarcomas. And this is the list of the staging parameters we use for soft tissue sarcoma to help orthopedic surgeons decide if they want to do limb salvage surgery or amputation. We will go over the staging in the next slides. Also with MRI scan, you can actually sometimes characterize the tumors. There are some benign tumors that you may be able to characterize with MRI. We'll see examples of those. The problem with MRI characterization, however, is when it comes to distinguishing some complex benign lesions versus malignant tumors because of the overlap in the signal intensity. There's also overlap in the signal intensity within malignant group as well, and we'll see examples of that. And this is the major challenge with MRI scan, is sometimes the non-specific signal intensity of these soft tissue tumors. MRI scan is also helpful to detect the area for the biopsy selection, because sometimes you may have a cystic lesion with a solid component, or you may have a necrotic tumor. So MRI scan will help decide which part of the tumor is suitable for the biopsy. We also need MRI scan for those patients who had surgical resection of the tumor. They come back for follow-up imaging to assess for tumor recurrence. So that's really the role of MRI scan in a nutshell, how we use MRI scan in our center. The MRI scan, why is MRI scan very helpful for soft tissue tumor, is obviously because MRI scan provides really optimum soft tissue contrast. It's superior to CT scan when it comes to soft tissue contrast. Also, MRI scan provides us with multiplanar imaging capabilities. There is no ionization radiation involved with MRI scan, so it's safer than CT. The problem with MRI scan, as I mentioned earlier, is the poor detection of soft tissue calcification or mineralization. So that's where CT scan can actually help you. An example of that is myositis ossificans, for example. And now move on to the techniques. How do we do the MRI scan for soft tissue sarcomas? At least in the centers where I worked in the biggest tumor center in London and the biggest tumor center in Toronto. And so this talk is really a combination of different practices that I have seen in one of the biggest tumor centers in the world. So for MRI technique, we always aim for image optimization. And image optimization starts with patient positioning. Whether you decide to image the patient in a supine position or in a prone position, and what position of the limb, if it is in the upper limb or in the lower limb, how do you position it in the MRI scanner? We will see examples of those. What coil do you use for imaging of the extremity tumor? And what pulse sequences you need for imaging soft tissue sarcomas? Will cover all of these. But all of these parameters and your choices really depend on the tumor itself that you are imaging. It depends on the size of the tumor, the location of the tumor, and the nature of the tumor, whether it is a cystic tumor, solid tumor, or hemorrhagic tumor. All of these factors will help you kind of decide on all the other terms of technique. So, for example, with patient positioning, when we image patients with soft tissue sarcomas, we would always aim to image the patient in a supine position because that's the most comfortable position for the patients. However, instances where supine position may not really be achievable, an example of that is if you have, for example, a soft tissue mass on the back of the trunk. And in this situation, you would need to image the patient in a prone position, because if you image the patient in a supine position, then you will detect it or characterize it or even do local staging on it. This is an example how tumor location may affect your MRI technique and patient positioning in the MRI scanner. And the benefit for doing, for example, this position is, as I mentioned, is to avoid image distortion and also minimize the motion artifact. Another example of how positioning could help you optimize the MRI imaging is, for example, in this patient with the soft tissue tumor in the upper limb adjacent to the elbow. So if you image this patient with the arm by the side, then you will get image distortion because it's not isocentered in the MRI scanner. It lies in the periphery of the magnetic field. And because of the location in the periphery of the magnetic field, it becomes susceptible to image inhomogeneity and then failure of fat saturation. So in order to optimize the imaging for this patient, we would normally recommend putting the upper limb in the center of the MRI scanner. And in this situation, you will get more homogeneous magnetic field and therefore a better fat suppression and better optimization of the imaging. So this is how positioning of the patient could actually help you improve the image quality of the MRI. Another thing related to MRI technique is related to placing a skin marker. So there are different skin markers you can use, including vitamin E or gadolinium markers. It is always good practice and is always recommended to place a skin marker. In fact, two skin markers, one at the upper border of the tumor, and the second one is the inferior border of the tumor. So then you know the boundaries of the tumor. Um, there are clues that could actually help you decide where to place the skin markers. If patient had surgery previously for soft tissue sarcoma, then the surgical scar or surgical incision could be a place where you can actually put your skin markers on. If there's a visible or palpable mass, then also you need to place the skin markers at the boundaries of this mass. And obviously, if there are skin changes, inflammation, or sinus formation, then that would be a very good hint to where the tumor is. If you can't really find anything like that, then maybe just ask the patient where the mass is or if they feel any mass, and just to place the markers where patient is indicating or pointing out. Choosing your MRI coils is a very important factor with image optimization because coil plays a major role in the signal to noise ratio and also with the image resolution. Normally with MSK imaging, for example, if you were to image the foot and ankle or the knee joint, we would always aim for joint-specific coil. And that is because joint-specific coils are the best coils for image optimization and improvement of resolution. However, this is not the case with imaging soft tissue sarcomas or soft tissue tumors because you don't really know how big the tumor is. You don't know what the boundaries are. So therefore, using a joint-specific coil is not really a good option for soft tissue tumors. And in this situation, you really need to use a bigger coil, such as a body coil or a surface coil, in order to increase your field of view, and then you can include the tumor. The disadvantage for that, obviously, is that you're not going to get a very optimized signal to noise ratio because the coil is a much bigger coil and it doesn't really help you with increasing the resolution of the image. So that's exactly what I was talking about here. For example, in a patient with a large mass, then you will have a view by using a body coil, but then the drawback for that is your inferior signal to noise ratio and image resolution. So here, for example, we have a patient with a tumor in the hand. In this case, we used a local surface coil, and this local surface coil has better resolution and signal to noise ratio compared to a larger body coil, for example. So this is what I was talking about, is choosing the coil could actually significantly change your image quality and optimize the resolution of the image. So always assess how big the tumor is and how big the organ you're imaging, whether it is in the thigh or it's in the hand or it's in a finger, because each anatomic location would need a different coil to optimize the image. So here we have an example. This patient is actually is the same patient, same tumor. This one image on the left was obtained using a body coil, This one was imaged using a surface coil and also with a smaller field of view. And you can see actually here that the image quality has improved quite significantly by just changing the coil and changing the field of view. But also keeping the same slice thickness, 8 millimeter on both of them. You can see how the image resolution and the boundaries of the tumor are better defined on the image on the right. And same situation here we have with this patient with the soft tissue tumor. Here the image on the left using a body coil, image on the right using a surface coil. There is optimization of the image quality and the resolution. The other thing with MRI technique for soft tissue tumors is choosing the plane. Axial plane is always included in the protocol. So axial T1 and axial T2 fat saturated sequences are always present in the protocol. Now, how do you choose the second orthogonal plane? Whether you add a sagittal or a coronal plane, it really depends on what the tumor is. If the tumor is anterior or posterior in the upper limb or in the lower limb, then you do sagittal imaging. If the tumor is medial or lateral in the extremity, then you use the coronal plane. So that kind of helps you choose your secondary orthogonal plane for imaging soft tissue tumors. There are two rules in terms of the secondary orthogonal plane. The secondary orthogonal plane is designed to help assess the longitudinal dimension of the soft tissue tumor. The axial plane helps you with your staging, but the secondary orthogonal plane helps the surgeon assess where the upper margin is and where the lower margin is. So there are two rules with the secondary orthogonal plane. Rule number one, they should always see a normal tissue proximal and distal to the lesion. So if you did, for example, a sagittal plane on this patient, on this tumor, but your sagittal plane was small and you kind of missed part of the tumor, then it is not acceptable. So you have to increase your field of view until you see healthy tissue proximally and distally. So what that means by healthy tissue is that there is no tumor, there's no edema, and there's no enhancement. So you keep increasing your field of view until you get completely no tumor, no edema, and no enhancement. This is the major factor for the surgical decision and the surgical planning, because at the end of the day, the reason why we are doing the MRI scan is actually to help the sarcoma surgeon decide how big the surgical resection is and the free margin is. And rule number two, when you do the secondary orthogonal plane for soft tissue sarcomas, is that you should always have a fixed anatomic landmark proximal and distal to the tumor. An example of that for this patient with a soft tissue tumor in the thigh, the proximal landmark, bony landmark, is the greater trochanter, and the other secondary landmark distally is the femoral condyle. So always have to have a landmark proximal to the tumor and a landmark distal to the tumor. And again, this is really not helpful to us for tumor characterization, but it's helpful for the surgeons to decide their surgical planning or amputation, for example. Now move on to the MRI sequences. So how do we choose our MRI sequences? The MRI sequences, the T1 sequence is always included in the protocol, and you always have T1 in the axial plane and T1 in the secondary orthogonal plane, and also with the fluid-sensitive sequences, whether you choose T2 FATSAT or STIR sequence, always have to have one in the axial plane, and you also have it in the secondary orthogonal plane. The contrast-enhanced T1 fat-saturated sequence. So as I mentioned, I worked in different centers, and different centers have different approach to contrast-enhanced tumor imaging. Not all centers will give gadolinium liberally for all soft tissue tumors, but I have kind of identified certain indications for giving gadolinium for soft tissue tumors, and these include, for example, distinguishing tumor from hematoma, patients who have had surgery and they came back for follow-up. You always give them gadolinium because then you distinguish between tumor recurrence versus post-surgical scarring and fibrosis. Also, gadolinium helpful to distinguish between solid and cystic or necrotic lesions. Gadolinium, we normally give it for patients with fibromatosis. And also, sometimes gadolinium may be helpful to assess the biopsy site of the tumor. Now, if you look at the literature, there is a lot of emphasis now. There is kind of increasing interest in using diffusion-weighted imaging and ADC and soft tissue sarcomas. In my opinion, and from what I have seen in the literature, the evidence is not really very strong. So we don't use DWI or ADC in our practice because of the variability in interpretation of these sequences. With MRI sequences, T1 is always helpful, and the T1 is helpful for your anatomical assessment for staging, but also there are some tumors that have high T1 signal intensity, such as lipomatous lesions, hemorrhagic tumors, tumors with proteinaceous material, and melanomas. They always have high T1 signal intensity. Other than that, most of the soft tissue tumors will either have low or intermediate T1 signal intensity. So your differential diagnosis for soft tissue tumors with high T1 signal intensity is really limited to these four conditions. The T1 is really low. In the MRI protocol for the sequences, we always have the T2 fast saturated or stir sequence. And the reason why we have these is because it's very sensitive for tumor detection. It is also helpful for assessing peritumoral edema around the tumor. Sometimes surgeons have great emphasis on how big the tumor is. Although if you look at the evidence, some researchers would argue that perilesional edema may not necessarily suggest there is a tumor infiltration, and it is just a reactive change rather than tumor infiltration. There is a little bit of some basic physics we need to understand when it comes to T2 fast saturated sequence because it's relevant for soft tissue tumor imaging. So you know from the physics that fat saturation is a frequency selection technique. And for this frequency selection technique, in order for this to work, you have to have a homogeneous magnetic field. The problem is when you have inhomogeneous magnetic field, then the fat saturation or the frequency selection technique may fail. And an example of that is this patient with this soft tissue tumor. You don't really have fat saturation on the lateral side of the extremity. And the reason for that is because the limb is off-centered in the MRI scanner. And because it's off-centered in the MRI scanner, you have failure of the fat saturation or the frequency selection technique. There are also other examples how this magnetic field becomes inhomogeneous, and because then it becomes inhomogeneous, you get failure of fat separation, is if you have a larger field of view, if you have metal in the field of view, and also in anatomic areas where there's complex air soft tissue interface, for example, in the ankle and the wrist and around the shoulder. These areas are very notorious where you can actually get failure of fat saturation. So T2 fat saturation is not always the best sequence for imaging soft tissue tumors because of these problems that you may have. And because of that, you may actually need to use an inversion recovery technique, such as a stir sequence, for example. The stir sequence has a different physics for fat suppression. It does not use frequency selection technique. It uses inversion recovery method. And this inversion recovery method is not susceptible to the inhomogeneity of the magnetic field. And so that's the major advantage for the stir sequence. So even if you had metal, even if you had complex air soft tissue interface, it will still work. The problem with stir sequence is that the signal to noise ratio is inferior to T2 FAT-SAT technique. And because of that, then you need to increase your number of excitation, and that means longer scan time, and that may result in motion artifact because of patient fatigue. So here is kind of a trade-off between a T2 fat saturated technique. It is better in terms of signal to noise ratio, it's faster sequence, but it has a problem with a magnetic field inhomogeneity in these conditions we listed. And then because of that, you might need to ask the radiographer to actually change the imaging technique from T2 FAT-SAT inversion recovery. We always, when we image soft tissue tumors, we always kind of have a discussion with the MRI technologist that when they have a patient with a tumor and T2 is failing, then they can switch to a stir sequence. But that again means there's a longer scan time for the patient. So here we have an example. This is the image on the left is T2 fat saturated technique of a tumor around the shoulder, and because in the shoulder you have complex soft tissue interface, then you get failure of the fat saturation around the tumor. If you switch this to a stir sequence, you get far better fat saturation around the tumor. So you can see how we optimize the image quality by just simply switching the sequences. And another example here, you have the image on the left is, and that's because of a large field of view. And the larger view, this magnetic field becomes, and because far better fat saturation here. Another example is the presence of metal in this patient with soft tissue tumor. Here in the middle is technique, and you see saturation around the tumor. If you switch it to stir sequence, you get more homogeneous fat saturation. So again, image optimization by just understanding how these MRI sequences work, and in terms of selecting your patients for these MRI sequences. Now we move on to MRI staging, and ultimately the reason why we're doing the MRI scan for soft tissue tumors and soft tissue sarcomas is for staging, so then orthopedic surgeons can decide whether they want to do limb salvage surgery or amputation. So how do we do local staging tumors? This is your list basically for local staging. So when you do the staging, you need to comment on the size of the tumor, the location of the tumor, the presence of perilesional edema. You need to also comment on the compartmental involvement, which compartment is involved, the neurovascular involvement, joint involvement, and bony involvement. So that's your local staging checklist. You always have to have this in your when you are so here, for example, we have a patient with soft tissue involvement. So this may be salvage surgery because the tumor is very extended. And also we need to distinguish between two kind of situations involving the bone. But in the situation, in this patient, for example, it's a tumor in the bone, but extending into the soft tissue because of this large extraosseous mass. So always kind of make sure that when you are describing the tumors, special tumors with soft tissue component, is whether the tumor is actually arising from the bone with an extraosseous mass, or it's a soft tissue tumor with a bony involvement, because these are two different pathologies. They are two different situations. compartmental localization is the most important part of soft tissue sarcoma staging. So this is really what is going to decide, make the surgeon decide whether they do limb salvage or they do amputation. Um, and when we do this compartmental localization, we really need to know our anatomy. So which part of the extremity the tumor is situated. And that is the most important part for local staging. So maybe we take this case, we take one of the residents to describe this tumor.
السلام عليكم استاذ هارون، شلونك حبيبي؟
وعليكم السلام ورحمة الله.
اسف اني تاخرت شوي، كان دخولي للزوم مو سهل وهذه. اوكي دكتورة رشا جبار اذا موجودة ويانا.
بلى عمي موجودة. السلام عليكم.
عليكم السلام.
MRI section, Excel section, T2, T2 star, anti-1 showing there is a hyper-intense component of the intensity of the medial hyper-intensity of the muscle component. أعتقد this is vastus medialis muscle. In T2 star, the intensity is very hyper-intense signal intensity, and especially in T2 star, very hyper-intense signal intensity in the vastus medialis muscle. And أنا أعتقد إنه هي هذه vastus medialis muscle, and يعني there is no invasion into the subcutaneous tissue or fat, يعني well-defined outline, no invasion of the adjacent muscle, and the vessel and the neurovascular band look normal, يعني no invasion. البون cortical bone, no invasion to the cortex, intercortex of the bone, and no invasion to the bone. The lesion look well-defined, multiple septa, and heterogeneous hyper-intense in T2 star. I think it's sarcoma. I think so.
Okay, so do you think you can do compartmental localization?
And there is any mass effect on the popliteus and superficial venous vein.
Okay.
I think there is pressure.
Okay, so which part of the body is this? Where is it? Tumor?
This is the lower thigh, lower part of the thigh.
Okay, so how many compartments we have in the thigh?
We have medial, lateral, and posterior.
Yeah. So so what's the name of the muscular groups?
This is, I think, the lesion involve the medial part of the thigh, the medial compartment.
Yeah. So what's the name of the muscular group in the medial compartment?
Vastus medialis muscle.
So vastus medialis is actually in the quadriceps compartment. So we have three. Okay, so this is the reason why I actually showed you this image. The reason, our topic here is compartmental localization. And this is what I was need to know our anatomic compartments in each extremity. And this is the kind of a test case I gave you because I want to assess how much kind of depth you have with your compartmental anatomy. And this is quite important for local staging. As I said, we're doing the MRI here for local staging. In terms of knowing whether this tumor is myxomatous tumor or if it is a sarcoma, or if it's a liposarcoma, that's a secondary matter. The most important matter for the surgeon is which compartment is involved with this tumor. So this is how we need to go over the compartmental anatomy. So if we talk about the upper extremity in the arm, then we have the the posterior compartment here. So there are two compartments in the arm. And in the forearm, for example, we have the volar or flexor compartment, and we have the extensor, the interosseous membrane in the middle. So there are two compartments in the forearm. And here, for example, we have a patient who has a tumor in the forearm, but the tumor has involved the extensor compartment and also the flexor compartment. So there are two compartments involved in this patient. It's not just one compartment. And because there are two compartments involved in this patient, then surgical excision for limb salvage surgery is not easy. It's going to be really difficult for the surgeon to do limb salvage surgery on this patient. We'll end up having amputation, and the reason why is because there are two compartments involved. In the thigh, which is the case, okay. Yeah, so the case that you looked at was in the thigh. Compartments we have in the thigh, and there are three compartments in the thigh. There's the quadriceps compartment, there is the adductor compartment, and there is the hamstring compartment. So that's how this is the case that you looked at. And the case that you looked at, there were two compartments involved. It was the adductor compartment and the quadriceps compartment. So you talked about vastus medialis, and vastus medialis is in the quadriceps compartment, you are right. But then the tumor is also involving the adductor compartment. The other part of the staging, which we will be talking about, is always commenting on the neurovascular structure as well. So that's your compartmental anatomy for the thigh. Then your compartmental anatomy for the leg, you have compartments here. So you have the anterior compartment or the extensor compartment, you have the lateral compartment or the peroneal compartment, but then you have two layers for the superficial posterior compartment, and you have the deep posterior compartment. So knowing the compartmental anatomy is really important. And we have a patient here with a tumor in the lower limb, in the leg, and you see the tumor actually has violated three compartments, has violated the internal anterior compartment or the extensor compartment, the peroneal, deep posterior compartment. So the three compartments violated by this tumor, and because there are multiple compartments involved, limb salvage surgery is not going to be possible for this patient. So this patient will end up having amputation because of this compartmental problem. Okay, move on to case 2, if we have a resident.
دكتورة رواء إسماعيل. دكتورة رواء موجودة؟ دكتور سيزار.
نعم أستاذ، صباح الخير.
صباح الخير، تفضل.
May I ask just please for the exact location of the or please, if you don't mind, Ustad Harun.
So this is in the thigh, proximal thigh.
Okay, thank you. Okay, I can see a heterogeneous soft tissue mass lesion in the anterior compartment of the thigh, which is quadriceps group. The lesion is surrounding the femoral bone, but not invading or distracting the cortex of the femoral bone, and not extending to the subcutaneous fat region. So most likely soft tissue mass in the anterior compartment of the thigh.
Okay, so with local staging, if you were to do local staging on this patient, so remember we had a list of the criteria for local staging. Can you just go over the list for local staging?
Yes, as we said, the site is very important, first of all, on the location in regarding the compartment. We said this, the upper thigh, anterior compartment. And regarding the relation to the surrounding structures, as we said, it's in close contact to the femoral bone. And neurovascular bundle is located on the medial aspect of the mass, but I think they are not evolving with the mass.
Yeah. Okay, so how do you know the tumor is not involving the neurovascular structures?
There's a fat plane or fascia between the neurovascular bundle and the mass.
Exactly. Our next localization or local staging of the tumor is involvement of the neurovascular structures. So we talked about localization as one of the first things you do of tissue tumors. The second one is actually, and it is very important for the surgeons, always for between the tumor and the neurovascular structure is a good feature for the surgeons because they can actually remove the tumor without having to sacrifice the neurovascular structures. So in this situation, when we have fat plane between the tumor and the neurovascular structure, we call the neurovascular structures maintained. So there is presence of fat plane between the tumor and the neurovascular structures. And here also we have another example of a soft tissue tumor, lobulated soft tissue tumor. This one is actually in the hamstring compartment, and we see intact fat plane between the tumor and the neurovascular structures. And here we have a different situation. We have a patient with a soft tissue tumor, but there is loss of the fat plane between the tumor and the neurovascular structures. So this situation we call obliteration of the fat plane. So the fat plane is obliterated here. And obliteration of the fat plane is bad news for the patient because surgeons may not be able to remove the tumor without actually sacrificing the artery, for example, in this patient. Here we have also another example of a large soft tissue sarcoma with a loss of the fat plane between the tumor and the neurovascular structure. And again, this is very challenging for the surgeon to remove the tumor without removing the artery with it. Here we have even a worse situation because here we have a soft tissue tumor that is actually completely encircling the neurovascular structure. So in this case, we call it encasement of the neurovascular structures. And when there is encasement of the neurovascular structure, it is almost impossible to remove the tumor without sacrificing and the sciatic nerve as well. We don't have lymph node staging in soft tissue sarcoma. So this is the reason why I'm showing you this one. So lymphadenopathy is not part of soft tissue sarcoma because when sarcoma metastasizes, is actually the metastasis is hematogenous, is not lymphatic metastasis. So we don't really do lymphatic staging. So now we're going to move on to MRI characterization, which is basically talking about how can we use MRI scan to characterize soft tissue tumors. And what I mean by characterization of soft tissue tumors is can MRI scan distinguish between benign and malignant soft tissue tumors? And also can MRI scan or MRI technique tissue sarcoma it is? And the answer is really difficult here because MRI does not really have a great advantage for characterization of the tumors. And the reason for that is because most of the soft tissue tumors have non-specific signal intensity. As you can see, these ones here, there are 4 different soft tissue tumors, but all of them demonstrate heterogeneous high T2 signal intensity. And because of that, you can't really tell what type of soft tissue sarcoma it is. And sometimes you are lucky to actually detect the type of the soft tissue. Four different examples. They all look very similar on the T2 fat saturated sequence, but then when they behave in a different way. And if you look at the final diagnosis or pathology for this patient, so this one turned out to be a myxoma, this one was a myxoid liposarcoma, this one was a schwannoma, and this one was a ganglion cyst. But actually, if you remove the contrast, they all look very similar. Really, MRI scan, MRI as imaging modality does not really have a major role with characterization. And as I mentioned earlier, the major role for MRI is for local staging, it's not really for characterization. Okay, we have another case.
دكتورة لانشا.
نعم أستاذ. We have a large heterogeneous soft tissue mass within the posterior compartment of the left upper thigh. It is ISO to low signal intensity on high signal intensity on the T2 weight image. I think it's inside the vessels, but no involvement of the adjacent one, and surrounding mild reactionary changes in the soft tissue.
So which compartment is this?
Posterior. Left.
Upper limb or lower limb?
Upper limb. Lower limb.
Okay, which part of the lower limb?
Upper thigh.
Okay, so it's in the thigh. The compartment, we talked about the compartments in the thigh, so I'm going to give you three. Sorry?
Maybe posterior and medial involved.
Okay, so I'm going to give you three options: quadriceps compartment, adductor compartment, or hamstring compartment.
Hamstring.
Okay, so it's a hamstring. So the tumor is localized in the hamstring compartment, and we can see that the adductor compartment is actually not involved, is displaced. So there's displacement of the adductor compartment, but it's actually not involved. And T2 axial is the best sequence for your local staging. So this is a large lobulated soft tissue mass situated in the hamstring compartment with no involvement of the adductor compartment or the quadriceps compartment. Now, we talked about the neurovascular structures. So can you just remind me, what did you say about the neurovascular structures?
Encasing, I think this is when the I cannot localize it, but I think the one that located posteriorly, it could be the vessel and encased by the tumor. Yes.
These two.
It's okay, far away from the tumor.
Okay, so yeah, so this is actually not a. This is the reason why I asked you what you're dealing with, because in the thigh, the neurovascular structures are actually between the quadriceps compartment and the adductor compartment. So they are here in the adductor groove. So they are displaced, but there is no involvement of the neurovascular structures. There's also fat plane between the tumor and the bone. So this is actually, although it's a large mass, the mass is located in one compartment with no involvement of the bone, with no involvement of the neurovascular structures. So this one is actually a suitable case for limb salvage surgery, where the surgeon actually could go in and remove it without having to do amputation on this patient. The reason why I showed you this tumor is actually just exactly what you said. The signal characteristic is actually very non-specific on T1, and this is what you see with most of the soft tissue tumors, especially malignant soft tissue tumors. Most of the times, the T1 will show you either a low signal intensity or intermediate signal intensity, and the T2 will always be heterogeneous, high signal intensity. So that's really pretty much how soft tissue tumors and sarcomas will look like. They will look like this. They are very non-specific. So there's a great overlap in the signal characteristics between benign and malignant, and also within the malignant groups itself. And because of that, we published our article in the Journal of Medical Imaging and Radiation Oncology. And what we did, we used a combination of imaging parameters to stratify the in general into three groups. The low risk group, when you don't have any imaging features such as tumor more than 5 centimeters, no surrounding edema, and no heterogeneous enhancement. Absence of all these features will make the soft tissue tumor a low risk. If you have one of these imaging features here, it will make the tumor moderate risk. But if the tumor is more than 5 centimeters with edema, so you have two features rather than one feature, if you have combination of two features, it will make it a high risk. So again, that's the role of MRI. So one of the major advantages for having MRI, as I said earlier, is the local staging to help the sarcoma surgeon decide and plan on the management of the patient. And the second part of the MRI scan is actually to stratify the tumor into a high risk or medium risk or low risk. MRI scan is not really, for soft tissue sarcomas, is not really designed to give you histopathology diagnosis. It's not really going to give you histopathology. It's not meant to be to assess whether this is a spindle cell sarcoma or if this is MFH or this is a grade sarcoma. Is really designed to either give you local staging or stratifying the tumor. The reason why we did this article, we published it to stratify the risk group for these patients, is because the management it will be very different. So for a low risk group patients or low risk tumor, you just leave it alone. You don't have to do anything about it. The moderate risk tumors, you just need to do follow-up imaging on them to see if they grow up in size or they resolve. The high risk patient, however, this is the group that you need to do the biopsy on. So really the soft tissue biopsy on these patients, it is on these patients with larger than 5 centimeters and also surrounding edema. Now move on to the benign soft tissue tumor. So we'll see examples of benign. So when I said the signal characteristics are very non-specific, I was mainly referring to these sarcomas, the malignant tumors, where the signal characteristics are really non-specific. But there are sometimes benign soft tissue tumors where the signal characteristics are very diagnostic, very typical of specific soft tissue tumor that you may be able to detect on MRI scan and characterize on MRI scan. But the list is very small. For example, a lipoma, hemangioma, nerve sheath tumors, myxomas, and myositis ossificans, these are just a few handful list of cases able to use the MRI to characterize the tumor, and you can tell with confidence that you are dealing with a benign tumor. Okay, so now we have case number 4.
نختار دكتورة فاتن علاء.
نعم أستاذ، صباح الخير.
صباح الخير.
Multiple sagittal and axial section MRI, T1 and T2 fat sat show a well-defined lesion that is intense in T1, located at the lateral aspect of the knee joint, at the posterior compartment of the lower. I think it is in the leg, posterior upper leg, with some displacement of the muscle, no local invasion. Adjacent bone seems, cortical bone seems intact. there is some suppression and it's non-specific in signal intensity.
Sorry, why did you say non-specific?
It may be lipoma, it may have lipomatous major component, as I think.
So, is the fat cell inhomogeneous?
There's slight inhomogeneity at the lateral aspect or posterior aspect.
You mean this one?
Yes, yes.
Oh, so this is subcutaneous fat, is not in the tumor. So the tumor is here.
The tumor having a fat suppression, but the lateral aspect of the subcutaneous fat having some sort of inhomogeneity.
Okay, so
yes, the by fat suppression.
okay, so if we have a tumor that is high on T1 and has homogeneous fat suppression on T2 fat SAT, what do we call the tumor?
Lipomatous, mostly lipoma.
Okay, is it or a complicated lipoma?
There is no soft tissue components, no myxoid components, so mostly it is lipoma. Yes, no other components.
Okay, so this is a simple lipoma. And this is what I was talking about, that sometimes MRI scan actually may be able to give you characteristics of the soft tissue tumor, and you can tell with confidence that you are dealing. I know this is a large tumor, and sometimes it is with no evidence of malignant degeneration. This is still like a lipoma. It's a large lipoma. So this is how lipoma looks like. It looks bright on T1, and it has fat suppression. It may have septa within it. It may have necrosis, fibrosis, or inflammation. Just because they are large, they are prone to injury and trauma. So they may develop fibrosis and scarring internally. Okay, we have another case.
دكتورة مينا أم الشعبان. دكتورة مينا. دكتورة نورس مسعود. دكتورة نورس ماركو. نختار دكتورة شوف منو موجود. شوف هواية الطلاب ما موجودين. دز هنيدة.
نعم أستاذ صباح الخير.
صباح الخير تفضل.
So this is an AP and lateral view of the involving the lower forearm and the wrist joint, showing there are multiple calcified foci involving the soft tissue compartment, mainly the volar compartment of the forearm, multiple calcified foci distributed overall the volar compartment. This could be related to vascular malformation, venovascular malformation, could be hemangiomatous lesion.
Yeah, perfect. So this is a soft tissue hemangioma, and what you saw on the radiograph are the phlebolytes, soft tissue phlebolytes, and this is a soft tissue hemangioma or vascular malformation. And what we are seeing on the MRI scan, again, the tumor will have intermediate signal intensity on T1, but it's the presence of the interlacing fat. So this is the interlacing fat here. And also on the T2 fat saturated sequence, you will see that the tumor is predominantly hyperintense, and sometimes you may see flow void within it, and that's the presence of the vascular network within the tumor. Here is another example of a soft tissue. This is the fatty component within the tumor, and the high T2 signal intensity. It can be sometimes quite infiltrative, and sometimes you may see very prominent network surrounding network of vessels around the tumor, feeding vessels into the tumor. Okay, this is another example of an intra-articular soft tissue hemangioma, the sagittal and the axial images, another vascular tumor, left hip, and we see these flow void within the tumor because the tumor is highly vascular, so you get flow void within the tumor. And that's the axial images for the same patient. Can be quite infiltrative, the soft tissue vascular tumors. And here you see what we call the serpentine vessel because of the vascularity within the tumor. Okay, we have another case.
دكتورة ياسمين سلام.
نعم صباح الخير.
تفضلي صباحك.
AB and lateral view of the knee showing a posterior soft tissue mass lesion not extending into the bone. There is no associated calcification within it. Well-defined borders.
Like what?
يعني استاذ هو soft tissue يعني dense
Homogeneous, heterogeneous.
homogeneous.
There is any calcification?
There is no calcification, staff.
You have to tell.
No calcification within the mass lesion.
Which compartment?
At the posterior aspect of the lower
Yes.
thigh.
Sure.
What do you do next?
With ultrasound to characterize the lesion, to see it, and then another step. Section MRI of the lower thigh, showing axial and sagittal sections. This lesion looks iso-intense on T1 or يعني hypo-intense, bright signal intensity on STIR. Well defined with the preserved fat glands adjacent to the maintained, not breached. Is there any contrast?
Yeah, this is
The first axial image is the contrast?
yeah.
Homogeneous enhancement.
Okay, do you see any characteristic MRI images or features?
يعني يستطيع هي hypo on T1, hyper on T2 with enhancement after IV contrast. يعني there's no يعني حتى.
Okay, so what do you see here?
spindle shape.
Okay, so what do you think?
If it's arising from a neurovascular bundle.
Structure, yeah? And what do you,
Neurovascular structure.
okay, so what do you call this appearance here? So you have high signal intensity.
Kind of nerve sheath tumor.
So this is a nerve sheath tumor. So this is again another soft tissue. But at least for established sign where it is actually less hyperintense in the center, more hyperintense in the periphery. So that makes it more tumor or peripheral nerve tumor. And again, we see the same thing even on the sagittal plane. We see the target sign appearance. We have the tail sign, and the tail sign indicates that the tumor is arising, for example, from the sciatic nerve here. So that's again another feature to suggest that this is a peripheral nerve sheath tumor. Sometimes this is a different nerve sheath tumor. You have what we call split fat sign. So the split fat sign is another imaging appearance of peripheral nerve sheath tumor. So again, there are certain features that benign soft tissue tumors and describe them, and you can tell with confidence what the tumor might be. Okay, we have another case here.
دكتورة هند عبد الهاب. دكتورة هند. دكتور عبد الله جمال.
نعم أستاذ صباح الخير.
تفضل. صباح الخير.
Okay, so before you start, the image on the right is T2 fats. On the left is T1 contrast enhanced. So this is a gadolinium T1 fat saturated gadolinium enhanced, and this one is T2 fat sat.
نعم أستاذ. in the thigh show high signal intensity in fast sat enhancement in after the post contrast. يعني اللوكيشن تقريبا يعني nearly يعني lateral aspect of mid thigh I think.
Okay, can you do local staging?
نعم.
Can you do local staging?
يعني location intramuscular, mostly intramuscular.
Okay, which compartment?
Anterior to lateral compartment.
So which extremity is this?
Adductor muscle?
No, it's actually in the quadriceps compartment. The quadriceps compartment, this is the adductor compartment, this is the hamstring compartment, this is sciatic nerve. Femoris muscle here, and this is vastus intermedius muscle. Okay, so in terms of the signal characteristics, on T2 fat saturated, you said it's hyperintense.
Yes, hyperintense and heterogeneous enhancement post contrast.
Okay, where is the enhancement?
Mostly at periphery, and part of it at center.
Okay, so if we have mainly signal intensity mass with central enhancement, what do we call it?
يعني هو partial لفاسات ganglioma، يعني ممكن يعني يبقى يعني special for ganglioma يعني أو
Okay.
myxoma.
Yeah, this is a myxoma. Okay, so this is characteristic appearance for myxoma. It's very fluid signal intensity intramuscular lesion with central enhancement. Okay, differential diagnosis for it. The differences between a myxoma and a ganglion cyst is actually the enhancement. So if we have myxoma, will have central enhancement, peripheral and enhancement, a solid central enhancement. So this is how we distinguish. They're both of them intramuscular. For example, in this patient here and in this patient here, they both have intramuscular cystic lesion, but the contrast here helped you distinguish a myxoma from a ganglion cyst because they look very different on the contrast enhancement. Okay, we have another example, another case.
دكتور حسين حكيم. دكتور حسين حمود.
والاستاذ وعد، انا عماد. هواي من الطلبه دا يتواصلون اكو يعني بسبب امتحانات السادس النت مقطوع بمناطق يقدرون يتصلون، بس العفو للتوضيح يعني.
دعاء علي. دينا عصام.
نعم أستاذ، صباح الخير.
تفضل.
Multiple section MRI sagittal T2 with fat separation يعني T2 with another section is T2 fat separation showing a fluid signal intensity superiorly to the patellar يعني suprapatellar aspect. Posterior to the femur there is a well-defined lesion which is a hypointense signal intensity lobulated up.
So just to clarify, this is T2FS, okay?
Okay.
This is gradient recall echo.
Okay. The lesion is hypointense signal intensity, so the T1 and on the gradient echo any hypointense signal intensity. On fat suppression, peritumoral edema from the femur down to the posterior aspect of the upper leg.
So what is unique for?
The hypointense signal intensity. And
Okay,
T1.
And T2FS?
And T2FS, yes. It may be fibromatous tissue.
What, sorry?
Fibromatous tissue.
Yeah, fibromatosis is actually a good idea, but I gave you gradient recall echo sequence here. What do you see on the gradient recall?
Susceptibility.
Okay, what do we call it?
Susceptibility, any artifact or bloom artifact.
Okay, we call it bloom artifact.
Yes.
Okay, so what is the characteristic pathology that would have bloom artifact? So what is the tumor, all the sequences, and has bloom on the gradient?
ممكن دكتور يعني as it is lobulated outline and have a susceptibility and blooming artifact on the gradient, hypointense signal intensity in both T1 and 2, and the location of the lesion suggesting the pigmented bilionodular synovitis, as it is forming an erosion also on the posterior aspect of the femur.
Yeah, okay, so it's a PVNS, yeah. You're absolutely right. So what is characteristic about PVNS is actually it is low on all the sequences with the bloom artifact on the gradient. So this is exactly what you have here. Again, so this is one of the entities where MRI scan actually of another example of how MRI actually could help you detect and characterize some soft tissue tumors. So we were able to diagnose this one as PVNS just by looking at characteristic imaging features of the tumor and the signal intensity of the tumor. Okay, so this is another example of PVNS. What is really important about PVNS is that you have to make sure that you image the entire synovium. So sometimes PVNS can be multifocal, although you have tumor here in the popliteal fossa, because the imaging was incomplete, they missed the tumor here. So we had to recall the patient and actually do extended field of the upper portion of the suprapatellar recess, because the surgical treatment is very important here, and they do radiotherapy post-operatively to prevent recurrence. So if we did not bring this patient back, and if we did not include this part of the synovium, they would have missed this one treatment after surgery. So remember, with PVNS, entire synovium. So an image like this is not acceptable. Okay, we have another case.
دكتورة ولاء رافع. دكتورة رؤى. دكتورة رؤى. عبد الله جمال. دكتورة سرى خالد.
نعم السلام عليكم. Yes, here the lower limb showing the abnormal signal intensity in form of low signal intensity in T1 and T2 in the extensor aspect of extensor aspect of the foot and lower knee anterior to the tibia. يعني هو hypo intensity 1 و T2 homogeneous. يعني هو between either osteochondromatosis or pigmented villonodular synovitis. Here also could be hemophilia also here, or could be fibrous content. يعني هو multiple differential.
Okay, so
يعني أحتاج enhancement، أحتاج إذا أكو X-ray.
Okay, yeah, you're absolutely right. So this is extensor hallucis longus tendon here.
I don't think extensor hallucis. يعني متى يحضرني؟ يحضرني إما fibrous tumor، أما pigmented هم يجي له.
Sorry, pigmented what?
Pigmented villonodular هم يجي هنا.
Okay, so yeah,
أو
you are
ممكن
right.
الهيموفيليا.
It's a tendon sheath genital tumor. For intra-articular pigmented villonodular synovitis. If the tumor is involving the tendon sheath, the name is tenosynovial giant cell tumor. Okay, so it's a different, the terminology is different. They are the same kind of tumor, but the name is different. If it's in the tendon sheath, then it's tenosynovial giant cell tumor. Yeah, same thing. The signal characteristics is low on all the pulse sequences, just like how we saw that with PVNS. Okay, we have another case here.
دكتور وميض. دكتور وميض ويانا. دكتورة دينا حمود.
أستاذ صباح الخير.
صباح الخير، تفضل.
multiple section بس العفو multiple section MRI. I think it is showing ill-defined lesion in the posterior aspect, high signal in T2, يعني extension between the two bone.
Can you name the bones, please?
It's يعني تيبا and no, it is يعني this is a thigh يعني femur and ischial bone.
I'm sorry, what?
Is that it? Ischial tuberous, yeah, ischial bone and femur. It's the
Okay,
femur
so
and
ischial.
yes, and it's
Yeah.
the region between the ischio-femoral region. Yes,
Okay, yeah.
it's abnormal signal intensity involving the muscle and I think it is
Okay.
T1 يعني involving the muscle. It's يعني just abnormal signal intensity in the muscle between the femur and the ischium. I think it is ممكن يعني الاسكيوفيمورال impingement المصل between these بصراحة ما أتذكر، أعتقد بايرفورميس أو quadratus.
Okay, yeah, quadratus
بس
femoris.
just يعني abnormal signal intensity.
So quadratus femoris is actually here.
Quadratus femoris, yes.
This is the hamstring origin. Okay, this is
يعني ischiofemoral impingement.
yeah. Also, the topic of our lecture today is about soft tissue tumors. I think we already covered ischiofemoral impingement in the previous talk. So if we look at the tumor, so intense to the muscle, the tumor, it is hyperintense on T2 fat saturated. Yes. And what these
يعني تقريبا.
Okay, so it's the boundaries of the tumor. What do you say about the boundaries of the tumor?
Infiltrative.
Yes, so it's
infiltrative or
infiltrative, yes. Differential
I signal in T1 and
well, T1 is not really high signal. It's
so intense, yes. ممكن نخليه الساركوما يعني.
Well, this is that's okay. This one is difficult, a little difficult. This is fibromatosis. And the reason why we called it that, I mean, there was histopathology, but the margins of the tumor are very infiltrative. And fibromatosis can be sometimes very locally aggressive, as you can see with this one, because it's extended quite a bit. Even on the contrast, you see quite a bit of extension. They are associated with high local recurrence, even after surgical resection or radiotherapy. The T1 can be a little confusing. Sorry, the T2 can be a little confusing. T2 can be either bright or dark. And it depends on the cellularity of the sample. Was bright on T2. And this is because it's highly cellular. Then when the tumor loses the cellularity and becomes mature collagen tissue, it becomes dark on T2. So this is how fibromatosis sometimes can be If you see fibromatosis that's bright, it's probably early in the disease process. But then as the disease becomes more mature, it loses the T2 signal intensity and becomes dark. Okay, we have another example case.
دكتورة غفران عدنان ويانا.
نعم أستاذ.
تفضل.
And I think بالexternal compartment irregular border بالanterior compartment of the thigh.
Which exam هذا؟
CT scan.
Okay. So your suggestion about this?
يعني أستاذ تكون calcified و يعني 3 section MRI showing iso intensive and enhanced lesion. يعني diagnosis يعني إنه يمشي myositis or significance.
Yeah, you are very significant. So you see the reason why I showed you this case, how confusing MRI scan was. So you are very confident when I gave you this case, this image, you are very confident about myositis ossificans. But then when I showed you the MRI scan, it was a little confusing to you because it was iso-intense on T1, it was hyper-intense on T2, it was enhancing on contrast. If you did not have the CT, you probably would have called it sarcoma. So this is how CT scan can be helpful. So sometimes with soft tissue tumors, you have to be careful. So anything like this could be called sarcoma. But if you had an X-ray or CT scan showing you what we call a zonal phenomenon. So this is the zonal phenomenon. And zonal phenomenon is mature ossification in the periphery and less mature ossification in the center. So this zonal phenomenon is characteristic for myositis ossificans. To be honest with you, you don't even need a MRI scan for this patient. You could just call it myositis ossificans on CT. You don't need to do biopsy on this. You don't need to do MRI scan on this. You can just leave it alone. So it can be helpful. All right, now we move on to the last part of our talk, which is the malignant soft tissue tumors. So in the previous section, we tumors that may have characteristic imaging features. We talked about the lipoma, the peripheral nerve sheath tumor, the PVNS, the tenosynovial giant cell tumor, and myositis ossificans. All these soft tissue tumors, they demonstrated unique imaging features that would be helpful to narrow our differential diagnosis, and then we can tell from the imaging features what we're dealing with. But when we move on to malignant soft tissue tumors, it's a completely different story here. Okay, so we have an example here. We have a resident.
دكتور علي محمد ربط.
صباح الخير أستاذ.
صباح الخير.
صباح الخير.
تفضل.
multi-section MRI of the forearm show high signal in T2 lesion in the anterior compartment. Will define with the central enhancement. With central enhancement.
So what's your differential diagnosis?
Cystic lesion يعني.
So this is T1, this is T2FA, and this is contrast.
Sarcomatous change يعني.
Okay, so on T1 is actually hyperintense. Well, that means what?
Hemorrhage.
Okay, well, hemorrhage would not suppress on T2FS. So it's high on T1, but suppresses on T2FS.
Fat يعني.
So it's fat, yeah? Okay, that's fat. It's suppressed here. All right. And then within it, there is small nodule, which is not suppressing, and it's enhancing. This lesion that does not homogeneously suppress and has enhancement. What do you think the diagnosis would be?
Liposarcoma.
Yeah, so this is a liposarcoma. Okay, so this is your typical appearance of a liposarcoma. It's a lipomatous lesion. If you remember the one that we looked at when we looked at a simple uncomplicated lipoma, there was homogeneous fat saturation. Have homogeneous fat saturation because we have a nodule in the middle that is actually not suppressing and it's enhancing. So that is a worrisome appearance of a liposarcoma. Here we have another example of a liposarcoma. This is a lipomatous lesion, has lipomatous component and another part of the lesion that is not suppressing on the T2FS. So this is suppressing, but this is not suppressing here. So that makes it a liposarcoma. Now, there is a debate in the literature as to how to differentiate between a lipoma and a liposarcoma or well-differentiated liposarcoma. So the way we differentiate between a lipoma and well-differentiated liposarcoma is actually by looking at features. If patient is older patient, then the lesion is most likely more of a low-grade liposarcoma. If the tumor is more than 10 centimeters, thick septa within it, and if there is a non-adipose component. This is what we say about the non-adipose component. This is adipose component, this is non-adipose component. And here also we have another example, large lipomatous lesion with non-adipose component, and we do the fat saturation. Actually, you see multiple nodules that are not suppressing, multiple nodules not fat suppressing. So that makes it a liposarcoma. And here also we see the lesion, and that makes it again a liposarcoma. All right, we have another.
دكتورة أسيل.
مرحبا. الو.
تفضلي أسيل.
coronal section MRI T1 T1 and T2 fat cells. There is at the anterior compartment lower thigh. There is multiseptated lesion, large size. عفوا دكتور أكو enhancement ولا أنا خف؟
No, this is just coronal T1 and
يعني إذا الكورونا ستوري يعني معناها فات suppressed.
yeah, it's inversion recovery. So
يعني so it is suppressed. بس هي multiseptated يعني I think it is complex.
okay, so
يعني
on T1, what do you see?
الهاي signal intensity يا اما راح تكون فاتي يا اما راح تكون hemorrhage.
So the high signal intensity, which one?
بس لا دكتور this
So this is
yeah, this is the tumor.
the muscle on T1,
Mm.
and in the center of the tumor.
There's abnormal signal intensity, non-homogeneous, high signal.
Okay. It is high signal on T1. What do we call it?
يعني either hemorrhage راح تكون أو domatus.
Okay, so fat, yeah.
Fat.
Yeah, so fat on T1, yeah. So the tumor itself on the stir sequence looks like what? Yeah, so like you said, it was myxomatous, yeah?
Myxomatous tumor.
With myxomatous tumor with fat in it, what do we call it?
I don't know.
Okay, so this is myxomatous liposarcoma. So myxomatous liposarcoma is a subtype of liposarcoma. So this, for example, a liposarcoma is this one, this one, this one. Your typical liposarcoma, there is a and a small non-myxomatous component. So that's the typical liposarcoma. The myxomatous liposarcoma is the other way around. You have a small lipomatous component and a large myxomatous component. So that's how myxomatous liposarcoma looks different to the typical liposarcoma. Is a large lipomatous component, small non-lipomatous component. Myxomatous liposarcoma, small lipomatous component, large myxomatous component. Okay, so this is a myxoid liposarcoma. Okay, this is probably our final case.
ناخذ دكتور أحمد. دكتور أحمد فايز.
نعم أستاذ، السلام عليكم.
عليكم السلام، تفضل.
Axial CT scan on the left, axial CT scan of the pelvis, both soft tissue and bone window. There is a well-defined, smooth marginated calcified lesion seated within right iliac fossa, associated with the peripheral soft tissue component. Lesion away from the bone, no obvious cortical erosion. Any contrast, Dr. Harun?
No, this is just, I think this one here is less contrast, but it's really just to show you maybe if we focus on the bone window.
تمام، هو يعني calcified يعني calcified
Okay,
lesion
yeah.
within the soft tissue بالرايت iliac fossa. Associated with the يعني peripheral soft tissue component, lesion has no anterior extension to the anterior abdominal wall. no regional adenopathy يعني ممكن كديفرنشال diagnosis myositis ossificans
of soft tissue sarcoma with
malignant fibrosis, and also possible differential diagnosis chondrosarcoma.
Okay, that would be a rare type of chondrosarcoma. You're talking about extraskeletal or extraosseous chondrosarcoma, because chondrosarcoma normally is so a chondrosarcoma in the soft tissue is very rare, very rare. It's called extraskeletal chondrosarcoma. The most common calcified soft tissue tumor is what type of tumor?
This is a MRI of the pelvis, both T1, T2 fast suppression, and the post-contrast. A lesion has iso-intense of the T1 and the T2 with the peripheral hyperintension, faint post-contrast enhancement. ممكن possibility malignant fibrosis cytoma.
Okay, so the most common calcified soft tissue of soft tissue sarcoma, 30% of these tumors will have synovial attachment. There is no synovial origin. I think the tumor sarcoma when it was first described, and then the name was never changed. Even with reclassification of soft tissue tumors, they never changed it because it became so attached to the tumor. But you just need to remember there is no synovial attachment, there's no synovial origin. What is really special about synovial sarcoma is the fact that there is calcification, and the calcification is more central, and then peripherally there is a soft tissue mass, like you said. So because of that, we have what we call reverse zonal ossification. So I gave you here two examples. One is a myositis ossificans, and another one is synovial sarcoma. The myositis ossificans is a benign pathology, and it demonstrates zonal ossification, which is mature in the periphery and less mature in the center. Synovial sarcoma does the opposite. The ossification is more mature in the center and less mature in the periphery. So this reverse zonal phenomenon is malignant, zonal phenomenon is benign. So this is how we differentiate between them. So synovial sarcoma is very characteristic. And you need to remember that with synovial sarcoma, it is always helpful to either have an X-ray or CT, because MRI scan is going to miss the calcification. We can't really see the calcification on MRI scan. But this is one of the weaknesses of MRI scan. Okay, so just to conclude, with all the soft tissue tumors we talked about, whether they are the benign or the malignant ones, sometimes you may end up doing a biopsy. My advice is never do a biopsy without talking to sarcoma surgeons before, because sarcoma surgeons, when they size the biopsy track with the tumor, they need to know where you did the biopsy. And also they need to make sure that you did not contaminate compartments that were not involved by the tumor. So for example, if the tumor is in the hamstring compartment, then you always do the biopsy through the hamstring compartment. You cannot do it through the adductor compartment. You cannot do it through the quadriceps compartment, because if you do biopsy a hamstring tumor through the adductor compartment, you will end up contaminating the adductor compartment, and that will make the surgery very difficult, if not amputation. So if a tumor is localized, and this is what we talked about, is localization in the compartments or compartmental localization. Compartmental localization is very important to the surgeon. They want the tumor to be in one compartment. So if you do biopsy through another compartment and contaminate another compartment, they cannot do limb salvage surgery anymore. So always be careful with doing the biopsy. Don't do it unless you discuss the MRI scan with the sarcoma surgeon and make sure you don't contaminate compartments that are not involved by the tumor. The biopsy can either be done using ultrasound guidance or under CT guidance. Ultrasound guidance if they are superficial, if they are in the extremities. I only do CT guided biopsy if the tumor is deep in the pelvis or in the retroperitoneum. Okay, so to summarize the talk of the soft tissue tumors, we talked about the different roles of different imaging modalities. X-ray can be helpful to see a soft tissue mass or calcification or phlebolytics. Calcification might indicate a synovial sarcoma. Phlebolytics may indicate soft tissue hemangioma. We talked about the role of CT for detecting mineralization within the tumor, such as myositis ossificans and synovial sarcoma. The role of MRI scan is really for local staging and also for stratifying the tumor to a low risk, medium risk, or high risk. The signal characteristics in general of soft tissue tumors may not be very helpful, but there are certain tumors where the signal intensity can be characteristic and diagnostic, such as a lipoma, PVNS, tenosynovial giant cell tumor, or nerve sheath tumor. These ones can be quite specific and can be diagnostic, but majority of all the other tumors have really no specific MRI features. Most of them will have either low to intermediate T1 signal intensity and high T2 signal intensity. So then also there is a limited role for gadolinium in soft tissue tumors. We only use it in our center for fibromatosis. We only use it to distinguish between hematoma and soft tissue sarcoma. We use it for cystic tumors, and we use it for post-operative follow-up after resection of soft tissue sarcoma. That will help us differentiate between tumor recurrence versus post-surgical scarring. So that's really what we have covered in this talk. And if you have any questions, please feel free to ask me.